Thanks, Jen. Hi, everyone. I am Rachel Chassie. Thrilled to talk about this particularly worthwhile topic, in my humble opinion. Now, I think everyone says that about their topic, but I think anything that deals with the patient voice is particularly exciting. So now, before we get started, this is being recorded, and the slides and the recording will be available after today's session. Please feel free to reach out to us on social, and those links can be found in the slides afterwards. And as Jen mentioned earlier, we will have a Q&A at the end of this webinar. Do feel free to enter your questions directly into the Q&A panel on your screen, and we'll do our best to get to every question. But if we do miss your question, feel free to reach out to us directly afterwards. And we have two fantastic presenters today, and I'll let them introduce themselves and why they are excited about this particular topic. How about we get started with you, Karen?
Great. Thank you so much for inviting us to do this webinar today. I do have two disclosures. I'm on a National Institutes of Mental Health KO1 award, and I'm also on a NARCED Brain and Behavior award, and actually Rob and I are both on a PCORI award related to a comparative effectiveness trial. So just a little bit about me. My name is Karen Fortuna. I'm an assistant professor of psychiatry at Dartmouth College. My area of research has been working with peer support specialists in designing and delivering digital therapeutics in an effort to address early mortality experienced by individuals with a lived experience of a serious mental illness. And so when I speak about peer support specialists, I'm actually referring to individuals who have a lived experience of a serious mental illness, and they have been trained and accredited by their respective states to provide Medicaid reimbursable peer support services. This has been around, well, actually since the 1400s, but with Medicaid reimbursement that began in 2001. So peers are known to improve quality of care for individuals with a lived experience, also reducing hospitalizations, and decreasing inpatient admissions. And I can talk quite a bit about that, but just let me know if you have any other questions about the effectiveness of this group. And Rob and I have currently been engaging on developing and designing a digital therapeutic together. So pass it on to Rob to introduce himself.
So thanks, Karen. Thank you for having us both. I'm Rob Walker. I work for the Massachusetts Department of Mental Health, and I wear many hats. One is the policy hat. Two is I do contract administration for the state contract for peer support, and I'm also a certified peer specialist and a certified older adult peer specialist. So I come at this with in different angles, and I've been working together with Karen for about 4 years now. Thank you.
Fantastic. Next slide, please. Okay, so here is the rundown for today's webinar. For those of you who want to include the patient in development, but perhaps don't know quite where to start, you are in the right place today. Karen and Robert will guide us through case studies and success stories and provide us with some resources to dig into further. And from there, let's have Karen and Rob take it away.
Great, thank you. So this is a picture of the early institutionalizations where you have people with a lived experience of a serious mental illness, and there's this line of rocking chairs, and people have suggested during these early days in the institutionalizations that, you know, this is the most that these patients could do. This was their leisure time activity, sitting in rocking chairs. And that's actually not the case. So when we work with people with a lived experience, we've found that it's really important to understand the historical context of the people that we work with. And part of this historical context is these early days of the institutionalizations where Again, you have these rocking chairs. You have a lot of trauma that was experienced by individuals. You had experimentation on people with a lived experience. And also people were over-medicated. And so this trauma, historical trauma, is something that needs to be considered when we develop programs or digital therapeutics for people with a lived experience. So you can go to the next slide, please. So we know in digital mental health that there has been a fundamental challenge has been the uptake of digital mental health interventions. And this is also consistent with, non-digital therapeutics too. So we develop these programs and interventions, and it generally will take 17 years for them to actually get disseminated into the community. And then out of all the ones that have been developed, only 11% of them, there's actually uptake of these interventions. And so the majority of these have been developed by scientists, and there wasn't interaction with the actual community, asking them what their needs are and what their wants are. So as we see this in non-digital therapeutic interventions, we're beginning to see this too in digital therapeutics, where disengagement is really common. So we spend millions of dollars to develop digital therapeutics, and we see after about 2 weeks, people don't use these anymore. There's generally a large drop-off. And so with research and population health as well, there'll generally be a loss of intervention effect if people are withdrawing early. The data integrity of our intervention could lead to a misinterpretation of the findings if there's a lot of missing data. And so we could think that one of these interventions or digital therapeutics are really effective, but if there's a lot of missing data in that and we're making assumptions about the population, it actually may be inaccurate. Can you go to the next slide, please? So what the field has done is really work within other fields too, to combine, developing digital therapeutics using user-centered design. And so this is a consensus statement that was put out by some of our colleagues, and they suggested that all smartphone apps and e-technologies should be developed with the end user in mind. And so when we think about user-centered design, the methodologies used in this field of study, they use them in clinical environments. And so, for example, somebody may be developing a smartphone application or any other type of digital therapeutic, and they sit with an individual in a research type environment, and they ask them to use it, and they watch them as they use it and collect data. Generally, they'll make modifications based on their feedback for this. However, this is in a clinical environment, so really what we ask, like, what happens actually out there when people are in the real world, in their own environmental context. And so that's when we really want to understand the context of people using these digital therapeutics. And we also think about the field of user-centered design. As it developed over time, it was first designed so we would develop like certain types of computers, and the interface was designed for the engineers. And they realized that we need to develop something else so we can actually get people to engage and use these certain types of methodologies. And so the field was developing technology related to VCRs, or those large computers that people used to have with huge monitors. And so now we're still using user-centered design and those specific methodologies with new technologies such as AI. And other types of machine learning or natural language processing. And the field hasn't evolved yet to, how do you get at, increasing use or engagement with advanced or more sophisticated types of technologies. Can you go to the next slide, please?
So I want to talk a little bit about community engagement in psychiatry research, and it's actually in digital psychiatry and in non-digital psychiatry. So the people with lived experience, especially those of us who have grown up, if you will, in the public mental health system, have really a fundamental mistrust in research that there's sort of there's trauma from being part of the system, trauma from treatment rather than just trauma in the real world. So, and we also find that there's a cohort effect, that older adults have a much higher mistrust in the digital technology than younger adults. That really older adults, and by older, I mean probably people 50 and older, really have a mistrust in the passive monitoring part of digital technologies, and that's probably related to their instances of involuntary hospitalization and mistrust that technology and monitoring will lead to involuntary hospitalization. And there's a really low research participation in the United States, especially for people with serious and persistent mental illness and people that voluntarily sign up for that research. And all of this leads to an insufficient uptake in research findings. That we found that most of it's because the researchers and the digital platform developers haven't really engaged the peer community and the people with mental health concerns community in developing their app. That nobody asked us, well, would we use it after the app's developed, or how would we use it? And this leads to a lot of, as Karen said in the beginning, a lot of apps that are just on the shelf and not being used, and the money's not being, the money is really wasted in apps that aren't very useful. Next slide, please. So a lot of this is about marketing science, that it's really that to engage communities, you need customer communities to organize events, give feedback to the developers, post pictures and stories of people using their products, and that's a good use of social media, and that's part of what we've been doing. Karen's published an article in Nature magazine, I think that's going to be mentioned further on, that customer communities really show high levels of engagement with products, that really building the excitement about the app rather than having it just be communicated researcher to researcher, that people are motivated to help other customers using the app. And we found that people, when you engage communities like that, people are very loyal and recruit other people to be part of the community and to be part of the product development and use of the product. Next slide, please. So this is a picture of one of our community engagement meetings that we had as part of the PCORI grant, which Karen mentioned in the beginning in the disclosure part. So these are folks who are peer specialists who the researchers have worked to really try out this community engagement model, get peer specialists involved in the whole research process. And I guess probably not the most fun part of this whole operation was also getting peer specialists trained to be part of the IRB process, the Institutional Research Board process, that we really wanted people, peer specialists, to understand the entire research process and be part of that. And as I mentioned, this is in the article in Nature about community engagement, a starter pack for scientists. And I think, and there's a link in the PowerPoint presentation, which is going to be posted. Next slide, please.
Great, thanks, Rob. So getting to Rob's point about the need for community engagement in digital therapeutics, and how that is related to actually engagement or uptake of findings and research. So we recently completed a systematic review of all the digital peer support interventions in the world, and this is currently under review. And we found these digital peer support interventions that they were feasible, acceptable, and there's really promising evidence that these types of programs and interventions actually help people with symptom monitoring, symptom reduction, increasing quality of life. And so what we found too, which was most interesting, is that at the bottom here, it says studies with the highest engagement used active community engagement methods to develop digital peer support interventions. And so here what we did was we looked at all of the studies involved, and we stratified them by how the actual digital peer support therapeutic was developed. And so was it developed using community-based participatory research, or was it developed based on focus groups with people with a lived experience? And so from that, we found that there's two things. We found that there's a continuum of community engaged research. And so on the left-hand side of the continuum, you see community engagement as certain type of methodologies related that are very consultative, where people will conduct a focus group or, excuse me, a semi-structured interview to collect data from the end user. And when they have that data, the scientist evaluates the data and makes conclusions upon that. And we see that as a very consultative method. And then we have more moderate types of methods where you'll use other types of approaches where there is a little bit more active involvement from community members. So it's a combination of consultative approaches like focus groups and user-centered design. So you are including the end users, but you are, again, the scientists are making the final decisions based on the data. And then towards the right-hand side, the end side, it's these active levels of community engagement. And so this is where we see community engagement approaches, we see community-based participatory research, where the community members are really involved in the design and delivery of the intervention. They're involved generally as equal partners, and they have shared decision-making authority. And so what we found is that the consultative models, and also the moderate models with user-centered design and consultation, that engagement was actually pretty low. And when we compared it to these active models of community engagement and combined with user-centered design, engagement was the highest among all of these, which was really exciting to see. And I want to note here too that, you know, there is this continuum of community engagement, you know, going from consultative to more active models. And when we're working with specific populations that may have a historical context where there is, you know, potentially being traumatized in the past, or potentially, you know, there's a distrust with the research community, that, you know, a consultative approach may not be as effective working with that community as more of a community-based participatory approach. And so I guess I want to say that, like, it's not one size fits all. It's actually defining what community engagement model based on what population you're working with in their historical context. Next slide, please. Great. So here we have standards for digital mental health development. So Rob and a few colleagues of ours, we published a future research agenda for digital psychiatry and mental health care. And then we published this great article which just came out about, how do we enhance the standards and principles of digital therapeutic with this idea of recovery. And working with these colleagues on multiple papers and from multiple different institutions, which are all leaders in the field, people are suggesting that the combination of user-centered design with active community engagement models is going to be the best approach when we're working with vulnerable populations. And I recommend you check those out. They're pretty exciting articles, especially the Enhancing Standards and Principles for Digital Therapeutics with Recovery-Focused Guidelines. Rob and I were just actually, based on this article, Rob and I were actually just invited to participate with the American Psychiatric Association in evaluating their smartphone apps and, providing this lens or framework of recovery as we evaluate those. And so we're pretty excited about that. Do you mind going forward, please, in the slides? So we're going to talk about the work that Rob and I have done. So this peer support specialist and scientist challenge convention through UX, which is user-centered design, and the integration of community engagement. So we're going to talk about how we've developed PeerTech, which we're going to talk about a small pre-post study that we did, and it's really about the process. And exciting, based on our findings, we actually received quite a bit of funding to help us move forward in the program too. So if you can move forward, we can begin talking about how we've developed this. So here's an adaptive systems engineering approach. And so we developed this program called PeerTech, which is a peer-supported smartphone-based intervention that has been designed to address mental health and physical health, self-management among people with a lived experience. And so we know people with a lived experience of serious mental illness, they die up to 32 years earlier than the general population. And research has suggested that poor health behaviors such as poor diet and poor exercise are the leading causes of this early mortality that people with a lived experience experience. And so in that, we developed this intervention based off of this program developed called Integrated Illness Management Recovery, which is an evidence-based practice, and it's designed to address mental health and physical health self-management among people with serious mental illness. And so this has been evaluated in 2 randomized controlled trials. It has been seen to be very effective in decreasing hospitalizations and also increasing medical and psychiatric self-management. The original intervention was 12 months long. It's delivered by a master's level clinician. We found that this was a great intervention, but then when we looked at this in a later systematic review, we found that people weren't actually using it. And so Rob and I adapted it using this adaptive systems engineering approach, where we didn't just take this 200-page manual and put it on a smartphone application. We actually we went through this entire scientific process in developing it. And so the first thing we did was a requirements analysis. And so it was really understanding, what software requirements do we need in the smartphone application. And so, for example, one of the things that we looked at was, people have multi-morbidity. In the real world, people aren't just going to show up to a community mental health center or a hospital experiencing a serious mental illness and only one chronic health condition. We actually find that, it's usually a combinational approach where people with, we'll say, for example, schizophrenia, they'll show up also wanting care when they have COPD, they have diabetes, and they have cardiovascular disease. And so we wanted the capacity of the smartphone application to address any type of or any combination of mental health and physical health condition at the same time to make it so it was real world. So that's really the requirements analysis. And you can see our article on the bottom where it actually talks about all the features that we have in it. And so there's a system analysis and control. And so here's where we selected the platform in designing the technology. At this point, we did not know we wanted to use a smartphone application, but as we're seeing more and more people with a lived experience of serious mental illness owning and using smartphone applications, just as the general population uses these, we figured, well, this is a technology that people have on them all the time. We're not introducing a new technology that somebody has to learn. And so let's capitalize on a technology that people already own and know how to use. Finally, we went to the functional analysis and allocation. And so here, here is where we develop wireframes for the smartphone application, which we actually were updating as we speak. And so there's about 270 different wireframes on the app. And so these are the app pages. And so when somebody clicks on something in the app, we have the text and the content in that. And here we included videos and text that were determined in written in recovery language. And there's peer-led videos that describe their own stories of self-management to help others learn from these experiences. And then finally, we did some usability testing for this. And so we used the think aloud approach in combination with verbal probing. And so in that, you work with people in this very clinical environment where you sit down with the researcher, and as you go through a smartphone app, the researcher is asking you questions. So that's the process. This is the first part of the process we went through. Can you go to the next slide, please? Great. And so here, here's where we develop this community engaged research approach. And so again, I just want to reiterate that community engagement methodology is on a continuum. And, working with this specific population, that we decided that this really active community engagement approach would best meet the needs of the community. So here we see on the left-hand side that we have a peer research support team, and they provide their expertise in peer support services, in policy, in how to work with patients. And then on the right-hand side, we have this core investigative team where we bring forth the scientific evidence and also new methodologies for research. And in the middle here, we have this full partnership where there's complete shared decision-making authority and complete co-ownership of the products that we developed. And so here, we're replacing patienthood with collaboration, engagement, shared decision-making, co-learning, partnership, trust, transparency, and honesty. And so the team has been integral in helping us plan studies. And so you see the intervention development is actually developing the smartphone application and developing the actual intervention. Some of the amazing research questions that have been included in our studies have been, peer-driven. For example, peer colleagues wanted to include recovery types of outcomes or mechanisms of action on our distal outcome. And so we're really interested in early mortality in people with a lived experience. And so one of our colleagues brought forth to us, well, hope. Hope is a very important outcome for individuals. And if someone has no hope, how are they going to start taking care of themselves and working towards their own self-management of conditions? And so that's something that we hypothesize as a mechanism of action on self-management development and also on early mortality risk factors. And of course, implementation considerations. Our whole program and app has been designed with implementation in consideration early on. And also, our team helps conduct studies. They help with recruitment. They help with retention, intervention delivery, and then when we do focus groups, we have them on there as well. And so Rob mentioned too that peer support specialist as part of one of our co-design teams, they actually went through a research ethics training. That was a really great experience. And we're actually writing a manuscript on it now, discussing their perspectives of, a community member completing a research ethics training, which has really been designed for scientists, which is pretty fascinating. And then dissemination, we do social media and blogs, which Rob mentioned as well. And you'll see our website where all our blogs are and all our co-authored manuscripts. And then we give presentations around the country too, and they're co-facilitated by usually me and Rob. Then also they really helped us with developing relationships too. And what has been most important, I think, in developing this partnership, like how can you have a partnership with people with a lived experience? And here we included, for this partnership to happen, we included principles of peer support. So I'm just going to pass it on to Rob to discuss some of those principles of peer support.
So thank you, Karen. The partnership is really full in every sense of the word. That at first it blew my mind that a PhD Dartmouth researcher would actually want to hear what I have to say, but I think as the relationship developed and as the project developed, we really fed off each other in terms of what our hopes are, what our dreams are for the project. And I can't speak for Karen, but I think we supported each other through the project, through the development, and also personally, that it really was a full partnership and an important relationship. And that I think, I don't know if I'm supposed to say this, but when I look at some of the early articles about this project before I get on board, and then I looked at sort of the language and the person-centeredness of the articles that got written after I joined the team, it's a big difference, and I'm proud to be part of that influence.
Thanks, Rob. That's great. And so, as part of this community engaged research approach that we have, this is really similar to the idea of marketing science that Rob spoke to as well. So we involve in this research project community members in making decisions, and we include them as equal partners. And that, within this marketing science framework, is that leads to later engagement, and this is a known fact in research. You mind going to the next slide, please? Great. So talk about the app. So this is PeerTech, and here you see that we have a library that we have developed that's on the right-hand side. And so that is curriculum based in our classes. We have them in self-management of mental health and physical health conditions. We incorporated sections on in addressing loneliness among people with a lived experience as well, because we collected data from almost 300 certified peer specialists, and we found that loneliness is the #1 unmet need among the patient population. And we're actually finding too that when asked in a qualitative study, 40 individuals were finding themes and trends related to their perception of loneliness as being the major risk factor for early mortality in people with serious mental illness as well. So we really wanted to include that in there. And so we also have personalized goals, which is right below. There's a chat feature between a certified peer specialist and a patient. And then there's a wellness plan as well. So people could develop their own wellness plans related to mental health and physical health self-management. And then we include surveys as well. And so we are adding in surveys to look at loneliness among the specific population. And so let me describe the intervention to you now that you see the app. Would you mind going to the next page, please? All right, so the PeerTech classes, it happens over 12 weeks. And as this was adapted from the original intervention was 12 months, and now this is 12 weeks. And so a peer support specialist meets with a patient who has also a lived experience of a serious mental illness. They meet for 12 weeks, one-on-one in the community for 1 hour, and they go through these classes together, which are highly recovery focused, where we talk about stress as the stress vulnerability model, suggesting that stress is the major factor that exacerbates mental health and physical health. And so we focus on the connection between the brain and body, talk about how to use the medications effectively, practical facts on mental health and physical health, and then, how do you work with the healthcare system? So here we teach advocacy within the healthcare system. And then peer support is embedded throughout the intervention. And so when individuals are not together during this one-on-one hour session that they have over 12 weeks, individuals chat while people are out in the community, or people can access the library and look at some videos and texts on these areas to increase their ability to self-manage their conditions. And it's really exciting because we see as peer support specialists text participants in our study, we actually see participants engaging more in the actual smartphone app and looking at the library and watching videos. And so it may be a mechanism, of action on actual engagement in the smartphone app. Would you mind going to the next slide, please? All right, so we did a pre-post study. We did a pre-post study, and we looked at 10 individuals. We trained 3 peer support specialists to use the smartphone technology. And all the peer support specialists were over the age of 50, which is exciting. Participants in the study, I think the youngest age was 65 years old, going up to like 87 or something like that. And everyone was able to use the technology. Everyone found it acceptable. So here we established feasibility and acceptability, and we actually saw some signals that the app is effective on clinical outcomes. So we saw after this 3-month intervention that we saw an increase in a person's ability to manage their psychiatric symptoms. And this was statistically significant, which is surprising considering that there's only 10 people in the sample. And then we also saw improvements on measures of hope, quality of life, social support, medical self-management, and self-efficacy as well. And what's really, exciting about this, and what's also really evidence of this process that Rob and I have engaged on, is that we've received funding from 3 different organizations, federal funding and foundation funding to continue on with this work. So you mind going to the next slide, please?
So the peer specialists on the team really helped direct the scientific efforts. But before I go into this, I just wanted to mention that this community engagement process is useful for psychiatric and for medical applications. That really the psychiatric slant of this program really is part of medical care and really addressed the overall health and the overall physical and medical care of the individual. And it's important to realize that this is not just a separate sort of encapsulated part of an individual's life, that mental health is health. So what we did as part of the peer advisors is we helped modify what research, what we're investigating. We added the questions about hope and recovery, and that's what we all wanted to see answered. We helped the investigators decide about the frequency of the text messages. A community engagement team, in this case it was the peer specialist, but really helped on where to recruit, how to identify people that should take place in the study, and helped with training on technology and implementation. That there was some, because of the age of the first 10 people, there were some issues about the use of the technology. So peers and the researcher were jointly worked on helping train people and helping them get this up to speed with the technology. That we really helped interpret what the findings were of that study and really helped dissemination that what we found in this, using this app and in this process, was very important. And most of the people in the world don't read research journals, so it was very important to get the word out in channels that the end user understands and that perhaps some of the funders understand. So that's why we did a whole social media campaign about the results. Next slide, please. That part of the benefit of using community engagement for the end user design is that we worked on content that it's important to the community, that the researchers asked us, the community, what was important to have as content. That because the app was something that was important to the end user, there was a lot better engagement in the app and a lot more use of the app. That the recruitment and enrollment was more effective and less individuals declined enrollment when the peer specialist team explained to them what the project was about and what the benefits were to them. That people completed the study. There's a lot of dropout rate, especially for people. I think in any study there's a high dropout rate, so there's more effective retention. There's a higher potential for uptake in the real world, that when it's designed with the end user in mind, there's going to be a lot more uptake in clinical settings. That the community partners felt empowered, and with the co-learning with the researchers and the community partners, there was new ideas and insights, and with the voice of both of us together working on a problem, the sum was greater than if we both worked on it independently. So next slide.
Oh, actually, I think, could we go back real quick? I just
I'm sorry. Yep.
on that. Oh, no, you're good. Yeah, thanks, Rob. And, you know, I want to talk about this co-learning with partners and new ideas and insights. And Rob mentioned this about the idea of psychiatry, you know, and this isn't, when people have a mental health condition, the likelihood of having a comorbid physical health condition is a lot higher than people without a mental health condition. And so when we think about psychiatry, we should think about whole health. And so these ideas and insights have really come from the peer support community, who, you know, suggested that this integration of care of mental health and physical health is really important for this specific population of individuals. And again, going back to that idea of, you know, using technology to address, you know, multi-morbidity is one of the advantages of technology as well. And, you know, in discussing this, is, you know, too, we're learning, Rob mentioned this idea of passive monitoring. And so we've gone through this back and forth, you know, do we include this on the app? You know, this is really interesting. Maybe we should do some digital phenotyping, or maybe we should include some AI and natural language processing, where instead of having a live peer on the other end, you know, we have a computer, a bot. And, you know, speaking with individuals, 40 people in a qualitative study, again, you know, we're finding this cohort effect that, you know, people won't want to use an app that has, you know, passive monitoring type of features, or even these avatar features where there's a bot on the other end and not an actual live individual, because they speak to the importance of human connection, especially for a group that has been historically marginalized. and also has, 3.2 times higher rates of loneliness than the general population. And so this really gets back to this co-learning with partners and new ideas and insights. And so that's really just one example of how, this type of community engaged approach has really advanced our research to really meet the needs of the community members. And so this is what we've learned from our small pre-post study. And, if you look into the research, these are all known factors of community engagement in research. And so if you apply these methods, especially with vulnerable populations, you're going to find better engagement. You're going to find better recruitment and enrollment. You're going to find better uptake in the real world. And so if we want to make real world changes, it's really important to not only consider the clinical environment, which it's really consider the real world and how things actually work in the real world, because we don't want to, of course, spend millions of dollars on developing these applications that we find are effective, but then people aren't using them. And so, we hypothesize, and the research is suggesting that this approach of incorporating user-centered design in combination with community engaged research has been really effective and will lead to greater population health in the long run. So if you don't mind just going to the next slide, we have some great resources. So we have our social mission, which is the Collaborative for Recovery and Health. And so that's our web space, the collabrh.com. And so we have some of our articles on there that Rob and I have written, and also some of our other colleagues who are peer support specialists. And these are peer-reviewed articles in great journals. And you could see, as Rob said, you'll see the change in language from 2015 until now, because language is a really important part of working with the community, and not always using academic language, but using language that will be accepted by the community. And then we have some blog posts in there as well, which we disseminate to the patient population. So our results can be disseminated not only to scientists, but also to people who are utilizing services as well. And then there's the Future Research Addenda for Digital Geriatric Mental Health Care. And we also have our other program on developing recovery standards for mental health care as well that we could send out. So I just want to thank everyone. And now we're available for questions.
Okay, great, everyone. Thanks, Karen and Rob, for that fantastic presentation today. So we're going to try something. We're about to enter the Wild West together. So what we're going to do is start the Q&A portion. And so we're going to, if you've been using this time to sort of passively listen, or maybe you're driving while listening, pay attention really quickly. You're about to unmute everyone on the line so that some people can ask Q&A. So you're about to be unmuted. So if you do not have a question and you're not actively chiming in, do please focus back in and unmute yourself in just a moment. But I'd like to start the Q&A portion, and we'll go in order of where we received questions. So I'd like to start with Cindy. Cindy, are you still on the line? Are you able to ask your question?
I'm here. Can you hear me?
We can. Why don't you give yourself a quick introduction and then jump in with your question?
Well, first I want to thank you for what was an exquisite and really, really important presentation. So I am Cindy Gagan. I am a almost 25-year breast cancer survivor, and I have a lot of experience in the effectiveness of peer-to-peer support and research. And it's a challenge in traditional research to generate the enthusiasm for it, but the evidence for it is really, really critical. So I really want to thank you for this presentation. My question, I had a couple of them, and I think, Rob, you actually answered or addressed some of them, but the Medicaid reimbursement, is that specific to mental health? Because my experience is in oncology, and I was the CEO of an organization, a really big organization that got 40,000 patient contacts a year, but it really grew into a multi-million-dollar budget, and that's why it doesn't exist anymore. So the capacity building for this is critical, and I think you guys addressed how the standards can transcend lots of therapeutic areas. So in oncology, there were a lot of emotional needs, you know, treatment effects, fatigue, loneliness, a lot of the same things. So the Medicaid so to go back to my question, the Medicaid reimbursement, was that a specific to a code related to mental health?
Well, the quick answer is that varies by state.
Okay.
And I think it's unfolding. We're working with Mass General Hospital Engage, which is a project for oncology for people with serious and persistent mental illness, and we're working with them to help figure out how to integrate peer services, and which means how to bill for peer services in that activity. Yeah, so yeah, that's a definite barrier. So I think the reimbursement hasn't caught up with the science yet. So that's another uptake issue.
I think, you know, the science being the digital part, but I think there's evidence in the peer support part because it's not reimbursed, and it's the other part is it's hard to scale. I think this could be a really critical area for DiMe is the standardization, because community engagement is critical, but the peer support is what makes it this effective. Because I can't tell you how much effect we had as a hotline, this was before digital, helping to retain patients to traditional research because they want to drop out, and having a peer intervene or be there 24/7 in our case really made a difference.
Yeah, that makes sense. And we, you know, we find with peer support in combination with traditional services that that whole, you know, integrated approach, it doesn't just include the psychiatrist and the oncology provider, it also includes a peer support specialist to help the individual while they're not in a hospital environment, to help them while they're out there in the community. So I'm not surprised to hearing that, you know, peer support was critical in that role. And my guess too is that, you know, if you were to, you could tap that Medicaid reimbursement potentially under either a code for peer support or a code for wellness, if you addressed it as, you know, this is an integrated care issue where you have a mental health condition in combination with, you know, physical health conditions such as cancer or chronic health condition, because, you know, these things don't happen in isolation, just as Rob said. It's not just a physical health, it's the combination of the two. And so I'm pretty sure you could probably tap your state, or at least begin to advocate within your state to make those types of reimbursements, but tap onto that Medicaid code for peer support or wellness. We can chat further. That's specific to your state too. Just feel free to give us an email.
Yeah, thank you.
Yeah, of course.
Great, thanks Cindy for the fantastic question. Got another question here from David. David, are you still on the line?
Hi, yes, I am. I was just typing in. I'm actually on break and from lunch, and I was just about to exit the call to get back to patients. But can you hear me?
We sure can.
Okay, so my question was, I'll just ask briefly. Maybe I'll have to kind of maybe just listen to the replay for the answer. I think my question might have been answered when it was brought up about the live versus the AI using a bot versus. My question was, does the chat feature that's in the app, is it in real time, or does it include the ability to communicate live or launch a call with a health professional or peer support, trained peer support person?
Yeah, it is live, and it is monitored 9 a.m. to 5 p.m. And then we have this researchers monitor 24 hours a day just to ensure that if there's any suicidality in that, we encourage the peer support specialist, if they identify an unmet need, that they can work with their provider agency in setting up whatever need that is. Maybe it's, you know, a person's cluttering objects or something, or hoarding, then we can assist them in, you know, facilitating that need. The dashboard feature is that where the peer can see all of the individuals that they're working with, and it would be it would be easy enough to add a primary care provider as one of the people to help communicate or review what the peer is working on to maybe assist with referral or any type of individual care. I hope we caught you. If you didn't have to
Yep.
sign off, and I hope.
No, that helps. I guess I have one other quick question. Is there there's no telehealth, there's no face-to-face component to that? It's chat only right now.
Yes, it is chat only right now, and we're seeing that peers are able to facilitate health behavior change using chat. And we provide a naturalistic framework where we don't tell the peers what to say. We want them to use their own lived experience and provide peer support within that framework.
Okay.
So we're not like teaching CBT and doing it that way. Yep.
Great.
Plus,
Thank you very much.
Plus the peers engage in person with the individual. It's not just an application. There's individual contact on a weekly basis with the peer specialist.
Great. Thank you. And just to add, as a physical therapist, I love your whole health model, combining the mental with the physical for sure.
Oh, great. Thank you.
Thank you.
Awesome. Well, thanks everyone for all your questions and your time today. We are rounding out on the hour, and we'll take the cue from David that we all, our time is running up here. So there is a few more questions, and unfortunately we don't have time to discuss those live, but do feel free to reach out to everyone on the webinar through the DiMe Slack channel. It's very active, so go ahead and jump on there to ask your questions or contact the panelists directly through their social, which you can access through the slides after the recording. And so just a couple more things. Next slide, please. We'll talk about our journal club, which is coming up. Gosh, is that already next Tuesday? My goodness, we get into the winter months and it's just time just moves so quickly. So we have our next virtual journal club over digital medicine standards. And this has been a hot button in the field. So this is sure to be a fantastic conversation. So do feel free to sign up for this journal club coming up next Tuesday. Next slide, please. And then a quick shout out to our very next webinar, and this will be for December. And so Exertia, in combination with the American Medical Association, has put together some fantastic app guidelines for mHealth development. So that's going to be a very rich conversation. So do feel free to keep your eyes peeled for that information. Okay, next slide. Well, thank everyone so much for your time and your attention today and your interest. This was a great conversation. And again, do feel free to join us on DiMe if you haven't already. There's much more information there. So thank you again to Karen and to Rob for your fantastic insight and great presentation. And if any more questions, do feel free to reach out to us directly through Slack, through our social, and from the slides. Thanks, everyone.
Thank you.
Thank you.